Good afternoon, and thank you so much for the invitation to Erez, to the organizers. I'm very happy to explain a little bit about my book. So I'm going to start post book to set it up. So on September 19th, 2025, immigrant physicians unexpectedly came under threat. Trump signed an executive order that instituted a $100,000 processing fee for the H-1B visa. And this visa is an employer sponsored visa that allows US companies to temporarily employ foreign professionals who are considered skilled in specialty occupations. So while this was largely aimed at the tech industry, foreign physicians became collateral in this new arrangement. Hospitals, it turns out, routinely use this type of visa to fill their staff vacancies. So before this executive order, the cost of this was between $2,000 to $5,000 per visa application. So huge change after this executive order. Within a week, the American Medical Association, the largest medical organization in the country, and more than 60 other medical organizations warned that this policy would severely endanger care in already under-resourced urban and rural hospitals throughout the country. They stressed that there's a large number of immigrant physicians who staff these areas and care for millions of vulnerable patients. So in my book, The Care of Foreigners, I ask, how did this come to be? How is it that for the last 60 years, roughly a quarter of the physicians in the United States have been immigrants who disproportionately work as primary care providers in America's neglected urban and rural communities? And what have their experiences in this country been like? So to answer these questions, I recreate the journey of the first cohort of practitioners through a legislative, bureaucratic, clinical, political, and public sphere since 1965. So this migratory regime was initiated in 1965 with the passage of the Hart-Celler Immigration and Nationality Act. And it was a response to a geopolitical and a domestic concern. So prior to 1965, the most comprehensive piece of legislation passed in the United States was the 1924 bill, and it had two components: the Asian Exclusion Act, which is exactly what it sounds like, and a quota for immigrants from Southern and Eastern Europe. So by the 1960s, during the height of the Cold War, this kind of nativist, isolationist, very eugenic immigration policy was not going to hold water. As the United States was trying to enter into this new position as a superpower, it couldn't signal to the rest of the world that it was this closed kind of place. So lawmakers really feared that these emergent post-colonial Asian and African nations would get seduced by the communist sphere of influence, and they would be persuaded to join and lean that way instead of joining the United States. So immigration became this really important foreign policy tool to signal to these countries that the US was welcome, that they wanted these countries to enter into this capitalist orbit. On the domestic front, civil rights legislation forced desegregation of hospitals, and additionally, Medicare and Medicaid, which passed only 3 months prior to this piece of legislation in July, facilitated the entry of over 23 million high-need medical care users into the marketplace overnight. So now this question is, well, who's actually going to provide care for all of these new patients? Because as now, back then, there was this shortage of physicians. So in response to these two kinds of concerns, this geopolitical issue and this domestic concern, legislators included a provision in this Hart-Celler Immigration Act that expedited the entry of skilled labor if there existed a shortage in the United States, which there was. And they recruited physicians from strategic nations such as India, Pakistan, the Philippines, and later Nigeria to provide care across the country. So despite the clear need of these practitioners and their legal entry, organized medicine, which is kind of the medical establishment, was suspicious of their skills and their expertise. They were weary of these non-white professionals with accented English who were claiming a status and authority of physician. And I think really at the core of this sentiment was an issue of trust. So how do we know who you are, first of all? And how can we be sure that you possess the knowledge that you claim to have? So there was this deep reliance on bureaucratic procedure and excessive documentation to try to fix these individuals, figure out who they were, what they were about. And organized medicine instituted this elaborate documentary regime that was necessary to translate these practitioners from elsewhere into some kind of standardized US practitioner. So after successful completion of this bureaucratic process, a foreign physician was able to enter the clinic. And here they ran into additional challenges. So even if their paperwork was in order, often organized medicine was skeptical of these practitioners' ability to actually perform this kind of expertise, often deploying racialized and gendered critiques of these immigrant physicians. But nevertheless, despite these disparaging characterizations, immigrant physicians developed creative strategies and practices in order to yield successful therapeutic encounters. Finally, fast forwarding a little bit into the 1980s, they were frustrated by this ambivalence that they experienced. So on the one hand, they're being recruited and invited into the country to provide care where US physicians won't go. And on the other hand, they're being treated with this kind of suspicion once they arrived. And so they started to organize and demand better treatment. Their political awakening, I argue, recruited and remixed anti-colonial discourse as well as civil rights demands, and they framed their grievances in terms of employment around justice, this anti-discriminatory treatment that they wanted, and they really started to chart a course of political action. And in this collective effort, South Asian physicians really emerged as the most vocal contingent, spending time and resources to hire lobbyists, campaign for congressional representatives. They financed many campaigns, and they really started to, at every turn, challenge the American Medical Association's dismissive posture towards them. So I end with a reflection in the present and argue that in many ways, the care of foreigners really ends where it began. 60 years ago, there was a doctor shortage that was declared during the Cold War as communist threats loomed. And today, new shortages threaten the country while authoritarianism takes hold and xenophobia abounds. For immigrant physicians and the approximately 80 million patients who rely on them, healthcare precarity is compounded by these unpredictable immigration policies. And I argue we need bold, coordinated, comprehensive reform of both healthcare and immigration to secure reliable medical care for everybody in this country. Thank you.